right, everyone. I think we'll get started. Thank you so much, everyone, for joining us today for the Network for Healthy Populations seminar series. And I'm just going to start before opening the presentation with a land acknowledgement. And so we'd like to acknowledge the land on which the UTM campus and the region of Peel operates, which is part of the treaty lands and territories of the Mississaugas of the Credit. And for thousands of years, this land has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still home to many Indigenous people from across Turtle Island. And we are grateful to have the opportunity to work on this land. I'm also personally grateful to this land that has provided me with a place to live, work, and raise my family. And I recognize that this privilege comes from the stewardship and care of the Indigenous peoples who have lived here for millennia. And I'm coming to you from Toronto, which is covered by Treaty 13. So welcome, everyone, and thank you for attending today's Network for Healthy Population seminar entitled Building a Database to Advance Black Health Research and Equity in Canada, presented by Rayshawn White. And before I introduce you to our speaker today, I'll just quickly review some housekeeping items. So we appreciate audience members muting themselves during today's presentation. There'll be an opportunity for questions at the end of the session. We'll also be inviting questions through the chat as well as through the raise hand function. If you have questions during the event, just put them in the chat box and we'll do our best to get to them by the end. Lastly, please note that today's session is being recorded, and we will also make the recording available on our network's website for those who've missed it. So now I'd like to, oh, we lost our slides. Oh, you're putting the next one up. Yes. Okay, great. So now I'd like to introduce you to our speaker today. Rayshawn Jade White is a recent graduate from the University of Toronto, where she completed studies in psychology, anthropology, and biology to gain a multidisciplinary understanding of the social and scientific factors shaping healthcare. She is currently pursuing a postgraduate program in health studies at Toronto Metropolitan University, focusing on critical analysis, ethical considerations, and community health initiatives. With a passion for advancing health equity, which is a core mission of ours at the network, Rayshawn is working to build the knowledge and skills necessary to become a strong advocate for Black, African, and Caribbean communities in Canada. As a Black identifying woman herself, this field of healthcare is especially important to her. Previous experiences in the Canadian healthcare system have emboldened and empowered her to make a key difference in her community. And this collaborative work emphasizes the importance of inclusive, accessible, and community-centered approaches to healthcare that take into account the complex intersections of race, economics, immigration status, and language barriers. And we're really thrilled to have her here to speak about the work that she's been doing in this space today. So please take it away, Rayshawn.
Hi, and good afternoon. So as Lorraine so helpfully introduced, my name is Rayshawn, and I am a recent graduate from the University of Toronto. And after previous collaboration with the library, I was intrigued by this project. As a Black woman who has navigated the intricacies of the Canadian healthcare system, I was interested in this project as it allowed me to explore the complex relationships between race, identity, society, and in the context of healthcare access and experiences for Black identifying people. And before I continue, I would just like to acknowledge my supervisors who helped me along. First, I'd like to acknowledge David Gristel, who is a research services and liaison librarian, there he is waving, at the University of Toronto Mississauga Library. And I would also like to acknowledge Maria Ruiz, who is a reference and instruction librarian at the UTM Library. These two helped co-supervise our summer 2024 project, which was building the Black Canadian healthcare research database, as you can see on the screen. And so let me begin. So first, I'd just like to say the disclosure statement. And then, so the origins and the purpose of this database. We were detailing, the idea for this database came from challenges that students kept running into at the UTM library. Students who were doing health science research on equity-seeking populations, so looking at social determinants of health. And when they came to librarians such as David and Maria, hoping to find literature on racialized populations in Canada, there was almost nothing available. students would end up having to draw from American research instead, which isn't necessarily ideal. So, when looking into why this gap exists, we find it's because Canadian hospitals and healthcare practitioners um, do not traditionally collect data on patients' racial identification. Critics call this the colorblind or race neutral approach, and while this reflects Canada's commitment to multiculturalism, it leaves us with a major unanswered questions about Black Canadians' healthcare. What are the health impacts of housing, policing, systemic racism? What about the need for culturally sensitive care? And how are patients, practitioners, and advocates supposed to find evidence based answers when the populations affected aren't even represented in the research? So, upon this realization, we needed to locate hard to find information that does exist, both in professional databases and in gray literature like community reports, white papers, and publications, and make this accessible in one place. So, again, there is David and Maria. And so this project was made possible by the University of Toronto Black Research Network's Ignite grant. And we also received extensive and generous support from the administration, librarians, and staff at the UTM Library and the UTM Office of the Vice President and Principal. So, on our agenda today, we will be talking about the introduction, who I am, as well as my other research assistants, our project timeline, methodology, the database design, limitations of the project, future directions, project implementation and impact, and finally, the conclusion. So, so these are my fellow research assistants. These include Ezina Arki, who is a student studying pharmacology and global health. She was drawn to this project due to challenges she had faced doing research on Black populations. In her first year, a research project on female genital mutilation in Somalia sparked her interest in how individuals with complications from cultural practices receive treatment in Canada. And this data gap motivated her to pursue collecting race-based data in Canada, aligning perfectly with this project, as well as Liz Ramona Makwitwanje. Liz Ramona is currently pursuing an undergraduate degree at U of T, majoring in ecology and evolutionary biology, health and disease, with a certificate in sustainability. After working as a research assistant at the Trinity College Food Systems Labs during her second year, she became acutely aware of the importance of food in creating and sustaining healthy populations. Her experience inspired her to explore the intersection between food security, justice, and the health of Black communities in Canada. So, beginning with our project timeline. The initial week of our research project established the foundational framework by introducing the project's rationale and objectives. My supervisors provided an overview of preliminary sources and facilitated discussion that regarded identifying gaps in the existing literature. Then we moved on to developing a comprehensive search strategy in the second week. Therefore, we identified key terms and systematically combined them in relevant variations to optimize our literature review and our literature retrieval. In the third week, we began to refine our search strategy while simultaneously gathering available and relevant literature from academic databases and repositories. Through weeks 4 through 6, we engaged in a critical analysis of the compiled literature, evaluating methodological rigor, identifying information gaps, and assessing the validity and applicability of our findings to our research questions. Weeks 6 through 9, we conducted a systematic review of the literature and established inclusion criteria based on insights from our previous critical analysis. This process enabled us to curate a refined collection of materials for the database. Weeks 10 through 11, we initiated correspondence with authors, community partners to address outstanding questions and establish a collaborative relationship for potential future research endeavors. The 12th week was dedicated to logging the metadata and the development of a taxonomic framework to categorize and organize the gathered information systematically. And finally, we concluded our summer phase of this project by disseminating our findings to key stakeholders, including University of Toronto faculty, staff, and community partners through a formal presentation, of which I get to share through Novo Nordisk today. So, what is a database? The database aims to serve as an academic and non-academic resource center with scholarly papers and gray literature. Our aim is to bridge the gap between science and society, empowering both healthcare professionals and everyday people with the knowledge they need to understand and transform their place in the Canadian healthcare system. methodology. So in order to get an idea of what we would be using in our database, we needed information that validates and represents the Black Canadian healthcare experience. Using a list of common complaints, genetic illnesses, and chronic conditions that disproportionately affected Black people, we came up with the following list, where we have, starting broad, everywhere from diabetes to maternal care and social determinants of health and accessibility. Following a systematic definitional work and iterative refinement, um, we identified what works. And while these searches yielded numerous results, as demonstrated in this slide, we recognize the necessity of establishing clear inclusion and exclusion criteria for our search processes. Consequently, when we compiled our list of core terminology to guide our literature retrieval according to our population concept and context framework. In more specific terms, the more relevant our results became, terms like racial disparity and racial biases, or distinguishing between women, girls, and female, gave us fewer results, but those results were more closely aligned with what we actually wanted to use. We also quickly ran into limitations. Our focus was strictly on health and healthcare issues for Black Canadians, and as there was very little research in this area, that meant we had to exclude articles on social determinants that weren't necessarily tied to health in their name. So food insecurity, even though it relates to health outcomes, we also had to omit research from American or UK contexts unless it was used for a direct comparison. The challenge here was glaringly obvious. Confronting the lack of race-based data in Canadian literature meant a precarious balance between reality and specificity. So those were our results. So here is a real-time visual of the informational gap using the three databases assigned to each research assistant. I use the following terminology and criteria to illustrate just how jarring the results can appear. Canadian healthcare was a term that had to be included, but only comprised about 45% of each database, and that is a healthy assumption. When including Black before Canadian healthcare, as it is the desired demographic, and filtering out author name, which was something that we hadn't thought of previously, one database failed to yield any results while another underperformed. And then we thought about accessibility. This database is meant for everyone, so that means everything had to be open access or free to read. From patients to policymakers to physicians, the results yielded above, we can see an unequal ability to access information without specific criteria and without specific credentials. So some criterion as seen did not yield any or very marginal results, meaning that we have a long way to go in order to produce and make accessible information that is integral to how populations understand not only their own health, but the health of everybody involved. So we also used grey literature. So to ensure a comprehensive review, we relied on multiple sources of grey literature, materials that are produced outside traditional academic publishing, such as reports, working papers, and government documents. We began with a basic internet search, which is often the first step for most individuals seeking information. Who here hasn't gone to Google and asked themselves, I have this symptom and that symptom, and popped up on a WebMD page that says you now have stage 4 toe cancer, This meant sources that matched our defined search strategy and included blogs, opinion pieces, and even podcasts. For more reliable and fact-driven information, we turned to government reports. Specifically, we focused on documents from federal and provincial health departments, as these reports were invaluable for their official statistics and offering a foundation of credible data to include in our database. To capture a more human element and explore lived experiences, we examined resources from NGOs and community organizations. These sources provided critical perspectives of on-the-ground realities, which work to personify the human element of policy gaps and limitations. And finally, we searched for scholarly literature that wasn't necessarily rigorously academic, which included conference papers, unfinished studies, and even dissertation work. When it came to collaboration outreach, we came across some articles that required more information and outreach to the publicizing bodies. So, for example, there were a number of articles from the early 2020s about planned projects or initiatives which did not have any follow-up. Additionally, there were articles that were not publicly available but would have been valuable in the database. We reached out to organizations such as CIHI and PHAC, and we were also contacted some authors of non-publicly accessible articles in order to see if we could work around some of the publishing, the databases, policies. We were successful in connecting with some of these individuals, and we are very grateful for their support and collaboration. In combining all of these sources, we ensured our analysis was well-rounded, incorporating both established data and grassroots perspectives. So onto the database design and structure. The categorization process. We employed multiple strategies to develop our final categorization system. So it started with reading articles and identifying recurring themes and using these themes to establish categories. We used Zotero tags, ChatGPT and AI to help really develop a framework of what people were searching for. From there, we identified those common themes and through the Zotero tagging system, and we tracked these frequently occurring terms and themes and phrases. So terminology such as specific illnesses, including LGBTQIA+, socioeconomics, incarceration, as you can see. So this was our adoption of an intersectional framework, which informed our keyword development and ChatGPT search queries to identify categories that reflect intersecting identities and experiences. So synthesizing our ideas, this is what our final database categorization looked like. So we started with our primary categories, which were physical health, mental health, and public health. And as you can see, each category was subdivided into secondary categories. For physical health, we branched into broad areas such as mental health and maternal health or chronic health conditions. Similarly, mental health branched into more common diagnosis of anxiety and depression, which can be further subdivided. And finally, public health was a term that we collectively decided would encompass all of the critiques, commentaries, and recording of experiences and articles that related to more social and economic aspects of health. Through there, our tertiary categories added more specificity to each article. So this includes discussions of specific illnesses under physical health, more niche mental health conditions such as mood disorders, psychotic disorders, and trauma-related disorders, and discussions from different stakeholders in the healthcare system. So critiques of the healthcare system or healthcare policy and the experiences of healthcare professionals, medical students, and everyday patients. As you can see in our green categories, we have the same theme of adding more specificity. We wanted to know about risk factors, treatments, resources, and supports. And finally, we created a tagging system. This tagging system would serve to function as being able to group similar articles together based on common theme. You could think of each article as a package. The category is the box, while the tag is the shipping label. If you are searching through articles, it's way easier to group them through categories as it is to much easier look at a shipping label than individually take apart each box. So for an example, as you can see here, if we had an article that impacts racism on maternal health during pregnancy, the main tag would be maternal health, a secondary tag would be pregnancy as it is related, and a tertiary tag would be anti-Black racism. We also included a race tag as Black people are a heterogeneous group, and that can range all the way from Afro-Caribbean or people who just identify as Black. So user experience was all the features and elements we hope to include to make the database accessible, user-friendly, and a community experience. So we wanted to have the gradient style system, as I previously showed you, so that we could structure our articles and they could be defined by their most relevant keyword and tag. So more adjacent to general terminology. In order to make this accessible for those with visual impairments, we decided to color grade it so that lighter colors meant closer to relevancy and darker colors equated to more broad ideas. A place for users to leave suggestions was our suggestion section so that they would be able to inform us about what we were lacking in the database. This way, it would be a true community-oriented project and an experience that gives back and benefits the community it serves so that the community could impart upon us and not just us imparting upon the community. Lastly, we had our community page for topics of community advocacy, support page, and locations that might be able to find services that seem necessary for accessibility. so that, for example, people would be able to find podiatrists in their area by looking on a map that we have tagged, or they'd be able to look for pop-up clinics or free clinics. We also wanted to include searching options that cater to new users versus experienced users. So those who have already navigated databases, such as university students, professors, those in academics, who would have the option to search by specificity in the search bar, whilst those who were new to this type of information might want the ability to start with something general, such as a physical illness, and narrow it down until they get to what they were looking for, perhaps diabetes management. Finally, our homepage would allow us to highlight the hot topics of the week. This would showcase the issues, experiences, or illnesses that the community was searching for a lot, and that traffic would be optimal in informing us, the back-end users, about what we can include more of in the future. So limitations and observations. As I've outlined many times throughout this presentation, information on Black health is scarce in Canada. And throughout that scarcity, there are patterns of inconsistency, obscurity, and overt ignorance that we noticed coming up time and time again. So, for example, we have lack of disease-specific information. So there were no research proposals or experimental trials going on. One that we really found frustrating was that no one was doing more than critiquing the issues at hand. So there were no productive commentaries coming up. Very few organizations, institutions, or individuals were coming up with guidelines to address the challenges and disparities. Another issue we found was that everything was based in the GTA, which is great for people who live in Toronto, Mississauga, around like the local Toronto area, but it failed to recognize the abundant Black populations in Alberta, say in the territories, or even Atlantic Canada. And there would be very select information would be available for those in rural areas of Ontario where this information might not apply in the same way it does here. Another thing was lack of intersectionality. As I've said again, research pertained to Black people, which is an identifier that fails to highlight the heterogeneity of our communities and reduces us to a singular people. There's little thought to how sexuality, gender, and religion affect the quote unquote Black experience amongst different populations. Another thing was the lack of objectivity, and non-objective research doesn't just provide poor information, it actively perpetuates systems that harm marginalized communities and make it harder to identify and address real health needs. Another thing was diverse sample sizes. Many experiments only had up to 6 participants or only had participants from urban areas with, again, lacking that rural aspect or the overall Canadian aspect. So we lack that interconnected identity piece, again, with intersectionality, but also it is hard to come up with a generalization when we are only using a very specific subset or a small amount of people. Some of the observations we noticed was that there was a strong and heavy emphasis on HIV research. And while it is important and necessary, its dominance without corresponding attention to the breadth of Black health experiences creates an incomplete and honestly harmful narrative that perpetuates inequality rather than addressing it. And finally, there was a lot of redundancy or a stereotypical introduction. So, in acknowledging historical context, its redundant and formulaic inclusion becomes more of a barrier rather than a bridge. Picture it more as researchers centering their guilt and awareness over Black people's actual informational needs. So, that then makes health resources less usable and potentially perpetuates the very inequities they claim to address. So there were also personal biases that we had to confront. Since we served as the final filters for the information gathered and presented, as a team of 3 researchers from diverse personal and academic backgrounds, we each brought unique perspectives to the analysis, but we also recognized that based on this, our reception and perception of the information varied. To address this, we ourselves had to engage in a lot of critical examination of all our sources. This included cross-referencing information, questioning biases both within the sources and our own, and deliberating as a group to ensure that the findings were both accurate and reflective of the nuanced realities we were aiming to highlight. So there are also some abundances in the literature review. So, from a bird's eye view, a notable trend is that much of the available literature consists of critiques. And as I mentioned in our limitations, these critiques often highlight systemic issues, policy gaps, and barriers to access within healthcare as they relate to Black communities, but they do not serve to add anything productive to the conversation. Again, there was a lot of specific focus on HIV and anemia as well as diabetes. And while these areas are well documented, likely due to their disproportionate impact on Black populations, we need more information on things outside of these illnesses. Additionally, we found a significant presence of groups and alliances dedicated to Black health. So this meant organizations that played essential roles in advocacy and community health initiatives. However, the recurring challenge there is the issue of continuity. Many of these groups face obstacles in sustaining their efforts over time, whether due to funding constraints, organizational capacity, or systemic barriers. So lastly, we have quality critiques. There is an abundance of low quality studies, and that might be due to low sample size and an importance of qualitative studies over quantitative. And again, many were extremely subjective. Um, there are numerous potential causes for this, again, such as funding, challenges in patient recruitment, and a lack of Black researchers and healthcare practitioners invested in these problems. But regardless of these reasons, this creates a cycle of low resources resulting in low quality studies, disincentivizing further investment and leading to more poor studies. So for future directions, we would like more of a larger geographic expansion. So this means that after the implementation of this database and when it goes live for the GTA, we want the possibility of this database being able to address the gaps Canada-wide, so nationwide. So that means using it in Alberta or using it in Nova Scotia, using it possibly in the Yukon. Another thing was further outreach and collaboration. There were, my apologies, there were numerous organizations, researchers, and scholars who are working to highlight and address the lack of race-based data in Canada, and we aim to partner with such bodies in future and to work towards a solution to these problems. Lastly, the impact. The entire purpose of this database is to have an impact and utility for everybody in our community, not just researchers. So future development of this project will explore ways to make the database accessible and useful to the general public. We also acknowledged some changes that we wanted to see, specifically more productive research. We would like to see government agencies, researchers, and academics prioritizing the productive research and data that we require so that initiatives that focus on modern relevant research in real time aren't wasted and we don't have to wait 10, 5, 15 years to see results. Another thing we want to see is more partnerships. So this issue goes just beyond medical authorities. This involves partnerships alongside legal agencies, public policy, and other industries that are interconnected in ways in which race affects healthcare. And finally, a participatory data governance. We would like to see the communities affected participating not just in the experimentation and trials, but to put forth their own ideas and suggestions as to what they want and what they need to help guide us to ensure that all practices, cultures, and trust are maintained and respected. So, in conclusion, this project provided us as students and for me as a recent grad with an invaluable opportunity to engage more critically with diverse materials and perspectives. Through this process, I not only got to deepen my understanding of the current landscape of Black health, but I also recognize the importance of questioning and challenging existing frameworks in day-to-day life. From the gaps we've observed, it's clear there is a significant room for growth and a need for a shift in how research is conducted. By adopting approaches that are more inclusive, sustainable, and community-centered, we can better address the needs of marginalized groups and create more impactful solutions. Thank you. And we now have questions.
Wonderful. Oh, Rayshawn, thank you for that very well-presented journey that you went through and clearly put a lot of work into this. So congratulations. I'm going to pass it on to Maria Ruiz, who's going to start with the question and answer.
Hi, everyone. Thank you so much for joining. Thank you, Rayshawn, for a fantastic presentation. So we now have some time for questions and answers. So if anybody has any questions about anything that Rayshawn covered, kind of the specifics of the project, the database more generally, anything about kind of maybe future directions that anyone is curious about, we would be happy to take those questions now.
I guess as people are thinking of questions, maybe I can ask you a question, Rayshawn. I recognize that this was very intentional to look specifically at the Canadian landscape and Canadian environment, and I think that was entirely appropriate. But have you had a peek at how any similar kind of work that's been done in the US? Because I know they do collect race data. I mean, it's very surface, but at least they're a little more advanced than we are in terms of collecting those data. And so have people, have there been any initiatives in the US that we could maybe learn from around, how to either improve the quality of the work, the data, or even have there been any kind of database type projects there that tried to put together some of the research?
So as far as I am aware, and in I would say probably in like the last 6 or so months of my own research, pertaining to my postgraduate studies, I have found that while the US does do a very, as you mentioned, surface level job of collecting race-based data, in the wake of some more administrative policy changes and legal changes, it's not as easy, I would say. Not so much in the form of accessing the data or collecting that data, but it more so comes from a logistics and funding perspective. So I know that a lot of communities where Black populations are higher, they collect, there are a lot of not institutions, there are a lot of organizations that aim to collect more like quality and more depth when it comes to the nuances in Black healthcare and perspectives. But I can't really pinpoint any specific organizations right now. And as we did use a bit of U.S. information to help us inform of what might represent or might mirror the Black Canadian experience. But so far, um, as I said previously, I don't think I can identify any specific organizations yet, but I would be glad to know of any.
Yeah, great. Thanks, Risha.
It looks like we have a question. Martin, please go ahead and unmute and ask your question.
Thank you. Thank you, Rayshawn, for presenting today. Um, I just wondering, I was listening to what you were saying about how we have GTA focused data or just more GTA focused as opposed to, Atlantic Canada and all those different places. I think the other part that makes it complicated is within Mississauga, for example, because it's part of the region of Peel, a lower municipality, then you have, Brampton, Caledon, and Mississauga as kind of clumped together. So I wonder if it's easier to get Peel data because I know that they are doing, they're being very intentional with gathering that data, but then you get a Peel perspective as opposed to a Mississauga, like a city perspective. You get a regional perspective. So I just wanted to throw that out there, and I was really curious about the way forward. Like, where do we go with this information? Because for those of you who don't know, I'm a city councilor and a regional councilor. This information comes into how we look at policing, the police budget, and when they're looking at mental health or specific cultures and how they work upstream. So this data is very, very valuable if we get it. But as you're pointing out, it's hard to find or it's not even possible to get it. So I'd love to hear a little bit more about the way forward. If you could speak to a regional perspective as opposed to just a city specific perspective on the work.
I keep forgetting to take myself off of mute. My apologies. Um, so yeah, based on the regional perspective, I know that for myself, as someone who lives in the city of Mississauga, it is easier, I guess, to really focus on the more, as you said, the regional perspective. So, Mississauga, Brampton, and Caledon, we have, the same police force. We have our Peel Police. We have our school systems and things like that. So I think from a regional perspective, I'm so sorry. I had a moment. I completely forgot what I was going to say. Do you mind repeating your question? I'm so sorry.
Uh, yeah, no, I was saying that it's difficult to get, I guess Mississauga content.
Hmm.
Like the Region of Peel does gather for Peel Public Health, and they have some data that they are gathering. So I was wondering, is it, speaking to it from perspective of a city versus a region, is it easier to gather that data? I don't know if, Dr. Lipscomb could probably speak to some of that work as well in terms of the data for the Region of Peel. But it's more just throwing that out there. I was more curious just about the way forward, like where do we go with this information and where we're at.
I would say, at least from my perspective, moving the way forward, especially when it comes to Black mental health. I know that within my own culture and my own community, it's heavily stigmatized. And from recent police reports and things, I know that we don't have, at least as a city of Mississauga and as a region of Peel, we don't really have a very condensed and like clear framework or guidelines for how to manage mental health and how people see that through different cultures, different communities, different practices, and how to respect that without resorting to, violence or any sort of thing like that, involuntary holds and institutionalization. And I think for me, the way forward would be to start like basically like at home, like starting with Peel Public Health, which I know has been doing some initiatives for gathering more health outreach. So how people in the community see health, how they access health, and how that informs, police budgets, as you said earlier, how that might inform school programming and just community education. So I think that's where I would like to see the database's impact helped and shift more, especially when it comes to mental health, as it is a very nuanced and not necessarily complicated topic, but it is a field where I think that in order to help, we need to stop looking at it from a problematic perspective and really get to the social and economic roots of that cause.
Great. Thank you.
Yeah, and to the point about, collecting data at the city level, I think part of it is as you say, is that there's that mandate for Region of Peel to collect data for their, from a health perspective, whereas, you know, um, sometimes it's often just also to do with numbers, right? So we try to look at some of those data by by municipalities or by regions, and then your numbers are getting really small because you're not it's you're not collecting on everyone. It gets challenging. So I think your point you said at the beginning, Rayshon, about how we're currently not collecting those information in healthcare. I think there's a lot of interest in incorporating more race, ethnicity, and other sociodemographic information as something that's being collected as part of healthcare, understanding how these characteristics actually influence somebody's health and healthcare. And so not just for research purposes, but also to direct healthcare, at the level of the clinical encounter, just understanding that person's background a little bit more. Yeah, so just wanted to add that.
Thank you so much. I can also add, just from the perspective kind of for me and David as librarians, as kind of supervisors for the project, it's this question of region versus municipality versus maybe provincial, federal. Part of the reason that we started this project is because it's so difficult to find these things. They're all dispersed, collected, slightly different in different places. So to move forward, we really want to be able to provide a place where all of this can kind of be put together, where people can easily access it, at least a little bit better through that lens. And hopefully once having those that kind of data, whether it be academic, whether it be more statistical, whether it be from different kind of organizations, will hopefully prompt some more studies of the kind that we've been talking about in terms of like, how does this actually affect, health outcomes? And once we do have maybe a little bit more data available, whether that be studies, whether that be kind of what is collected at the regional or municipal level, it will hopefully prompt more research into this. It won't kind of be so frustrating for researchers. And there might be more interest, and they'll kind of hopefully provide a positive feedback loop. So hopefully that answers your question, Martin. Amazing. We do have another question from, is it Beiju? I'm so sorry if I'm pronouncing that.
That's right. Yeah, no worries. Sorry. Thanks, Michelle, for presenting. I apologize. My camera is not working today, and I've had a gap between meetings all day long to try and fix it. So I will stay off of video. But I wanted to ask, I mean, you did highlight the fact that a lot of the research that you found that in your search was, a lot of it was focused around HIV, but you also mentioned anemia and diabetes. I mean, we're a diabetes group here. We're interested in diabetes. Are you able to give us a little bit of a sort of bird's eye view preview of what you found related to diabetes, or what was some of the research that had taken place?
So I actually can, because most of the research that I know that I did based off of how do I say this? When we started parsing up information and saying dividing it amongst us, a lot of the information that I had the privilege of disseminating and reviewing involved a lot about diabetes and a lot about diabetes access, diabetes care, and diagnosis. So when it came to that bird's eye view, what we really were seeing was that diabetes is identified as a big problem in the Black community within Toronto, the GTA, but it wasn't necessarily that diabetes was the main focus. It was always about a comorbidity. So it was often about diabetes and high blood pressure, which is another big thing I know, at least from my own research, when it comes to Caribbean Canadian people, especially Caribbean Canadian people who are Black and are recent immigrants. It was about immigration and diabetes. So when it came to looking at diabetes, and yes, you guys are the diabetes people, I thought to myself, why is there such an emphasis on diabetes, not necessarily from a point of research when it comes to are we doing enough research, or is this too much research? And does this place, are we unintentionally pathologizing Black people when it comes to diabetes? But I saw it more as the diabetes issue amongst Black people is something that we don't have a way forward with. I hope this makes sense. We don't have a clear cut set of rules or guidelines or criteria that we want to not submit, but follow when it comes to helping Black people either manage their diabetes, helping them know where to get diabetes management. And I will say most of this came from doing research on chiropodiatry and podiatry, because I know that diabetes affects I don't know if it affects the blood vessels. I'm not exactly a medical student. My apologies, but I know that people have a lot of foot issues, and I know personally, my own uncle has a lot of foot issues dealing with his diabetes. So it was researching places like communities, so cities like Mississauga, Brampton, areas such as like Etobicoke in like Rexdale, or around Jane and Finch, like those areas like that, where there were like a lot of podiatry clinics, or there was a lot of a demand for podiatrists, and it was going from that point of specificity and then looking out. So looking from, I guess, like at one podiatry clinic and then broadening out into that bird's eye view, that I was like, this is something that doesn't have a clear cut answer, but I want to know more about. And hopefully you guys will have more information about eventually.
That's great. Thanks very much. And you are correct. There are foot and blood vessel problems. So.
Thank you so much for your question. I'm going to go to a question we got in the chat. And so this comes from Batul. Oh, and I think David has kind of taken a look, but just really quickly, I think one of the challenges in disseminating this work and taking your work forward, given your interest in making this work accessible beyond geographies, have you pinpointed any specific networks, agencies, or community networks across Canada that can help facilitate the knowledge translation and dissemination process? Meaningful partnerships seem particularly essential in this work for creating an equity enhancing movement. And so, Rayshawn, do you want to talk about that for a little bit? I know that David's put an answer in the chat, but I think your perspective would be also quite valuable.
Oh, okay. Sorry about that. Yes, I have seen, I did see what David said in the chat in relating to the Black physicians of Ontario's, who do have insights about knowledge translation. I also got an informal like ask about our project from, I don't know if there was a representative or someone who works with the University Health Network. And I know they have like a lot of current projects, especially when it relates to Black youth in specific, and how using social media and culture to relay health information when it comes to Black youth and new immigrants who just happen to be adolescents and children. They have different programs for different cultures, different races and ethnicities. So I know for one that the University Health Network is someone that is an organization that hopefully we would be able to collaborate with, as well as the Canadian Institution on Health Information, because the CIHI is quite honest, is quite literally the place for health information in Canada. And so we did use some information from their like reports, their like annual reports, their quarterly reports. But again, as is the theme of this project, we weren't able to specifically identify productive productive research that when it came to Black people. There was one mention in the chat. Angela Carter asked me if I had ever spoken to the B3 community agency in my research, and I cannot say that I did. I don't know if any of my other research assistants did, but they sound like somebody that I might have to get into contact with in the future. So thank you for that, Angela. Yeah, that's probably the one place I know that we could the UHN we could collaborate with. Another person that I had the honor and joy of speaking to was Notisha Massaquoi, and she is a faculty at U of T. She is also the founder of Women's Health in Women's Hands, which is a community-run women's health center in Toronto. So she is also I believe she also holds a Master's of Social Work. So speaking with her offered a lot of different perspective on how to approach information and informational gaps through a more, when I say accessible, I mean from a more on the ground community way. So how do we get this information out to people, not just necessarily about how do we get people to come into using our database, but how do we get people who might not have the technology, the ability to get this information, and how we make this and promote this from a community perspective.
Amazing. Thanks so much, Rayshawn. One quick note that I will add is that we have had, as Rayshawn mentioned, some really good responses from community organizations that Rayshawn and her research assistants reached out to. And so we are constantly looking for any kind of discussions, partnerships that might be helpful to address the knowledge translation and dissemination portions of it, as well as providing us with insights on the best way to move forward, who to talk to. We want to make sure that this project stays as community-based as possible. And so any recommendations from anybody here would be fantastic. We are always looking for other potential partnerships to kind of follow up on. Great question. I'm going to hand the next question over to Dahlia, who has had the hand raised for a little bit. So please go ahead and unmute.
Hi there, thank you. I'm not sure if my voice is coming through. Is it too low of a volume?
Nope, we can hear you very well.
Okay, perfect. So first off, thank you so much, Risham, for this amazing presentation. And I want to extend my gratitude to you and the rest of your team for doing such critical work in a chronically overlooked and underfunded field of research. My question is more of a basic question. It's more so from my understanding, but just for some context, I'm a first-year public health student, and I run a nonprofit called Bridge Health Collaborative. We create evidence-based interventions to support the health needs of food bank clients in the Greater Toronto Area, which we all understand. Those communities are BIPOC communities, including newcomers and immigrants who are disproportionately affected by chronic conditions like type 2 diabetes, high cholesterol, and high blood pressure. So we're currently undertaking our very first literature review, looking at the health management experiences of these communities and looking at social determinants of health and existing interventions and et cetera. Can you speak a little bit more to the search strategy and how you created your research question? And then did you do a search of existing literature to refine your research question? And if so, what did that process look like?
Um, for one, thank you, Dahlia, for the question. And I really admire that you've like put together, as you said, your Bridge Health Collaborative. Um, that's something I wish I could have done when I was an undergrad. But you know what? I think it's great that there are like people like after me, um, who are doing things that help support Black communities. And based on your question, when it came to our search strategies, it was a long process of like we started off really ambitious. I remember between me and my other two research assistants, we started off really ambitious, and I remember doing some like preliminary research work, like without really logging anything or taking into account like what data I was looking for specifically. I remember doing just like basic searches of like Black health in Canada, Black people's health, health inequality in Canada, and this was through using like U of T's like Omni Library system as well as just basic Google searches, and I came to the realization that um, well, for one, yeah, there's a lack of that information, but two, if I wanted to get the information that I so desired, I had to be really specific, and I did share this with my other research assistants. So it did come from a place of already knowing, like as a Black person myself, that these are like A, B, and C were issues that we're already dealing with in the Black community. Um, like you said, diabetes and health management. Um, I knew that like diabetes and HIV and among other things, maternal health um, and health equity were big issues for Black people in general when it came to healthcare. And so, as I mentioned in our slides, we started with those specific things. So, like equality, equity, diabetes, searching that up and using more advanced searches and adding Black Canadian, Afro Caribbean, African Canadian. And it really came down to a point of we have to be specific to get what we want, and structuring those search strategies meant that we had to abandon certain things, because if you put perhaps food insecurity and Black, we weren't going to find anything because there is very little or absolutely no information when it comes to food insecurity in the Canadian context for Black populations. There is information about food insecurity among Canadians, but that doesn't reflect the Black experience. So and when it came to our research question, I'm pretty sure, if I remember correctly, I'm pretty sure David and Maria already had that going, as um, they were the librarians. The students were the ones coming to them and telling them, they said, I can't find anything. There isn't anything I could do. So it really, that question might be better answered by David or Maria when it came to how we came up with that research question.
Yeah, it's I can go into like a really brief Spark Notes version of it, but it really just kind of involves a process of beginning with main concepts that you're interested in. So you've seen a lot of the ones that we were interested in, kind of finding synonyms, finding related terms. There's lots of different ways that researchers can address these kinds of concepts, lots of different terms that they might use. And so it's kind of an iterative process of kind of doing a bit of a search, seeing how it goes, and also keeping an eye on how researchers in the literature express these ideas and these concepts, and then using that to kind of further refine. That is a very, very kind of broad explanation of the process, but it's kind of a combination of like, what is it that we're targeting? What are the terms that best kind of match to that? How do we refine these based on the literature? And then from there, you can kind of put together something that is a good mix between kind of broad, covers a lot of areas, but also is specific enough to be relevant. And if anybody's interested in that, you can always reach out to us for a more involved explanation. I think we have time for one more question. And so that will be from Candace in the chat. Thank you, Ray-Sean, for your presentation. Wondering if you came across any research or other literature that speaks to regaining or rebuilding trust in racialized communities around collecting data, whether that data be qualitative or quantitative, as I think this may be a huge barrier to collecting race-based data in the first place.
Thank you, Candace, for the question. And actually, that was something that we didn't come across much of at all. And I don't know if we successfully highlighted that in our presentation. But when it came to being able to, when it came to literature that speaks about the erosion of trust and medical distrust among racialized communities, most of what came up was really centering the, and without having a better word to say this, really centering a more like white guilt, quote unquote white guilt perspective. So it mostly came from non-racialized physicians, healthcare authorities, and policymakers understanding that they had done a great disservice in how they treat or how they didn't treat racialized communities. But I think that reflects our point that there was not a lot of productive research and there was not a lot of productive commentary being made. It was always it was always about identifying the problem firstly, and then speaking to how they were so sorry that they'd done this and that they need to move forward. But there was never a lot about how we will move forward. And even if there was any talk to how they would move forward, it was really superficial, very surface level. It was about, well, we should start collecting race-based data. Maybe we should start, investigating these communities directly. And all that is well and good, but, you know, intention without any sort of real impact is kind of more harmful, I would say, than good. But again, thank you for bringing that up because that is something that I do recall going through quite a bit.
Absolutely. Thank you so much, Ray-Sean, and thank you, Candace, for the question. I believe that is all the time that we have for today. Thank you, everyone, so much for joining. Lorraine, is there anything else before?
No, I just want to echo your to say as well. Thank you very much, Ray-Sean, for an excellent presentation. Thank you, Maria, for moderating so well, and thank you everyone for your contributions. You have a few things in the chat where people want to follow up with you, some suggestions for partnerships. So clearly you've generated a lot of interest and stimulated a lot of discussion from your work. So it's a great example, Ray-Sean, of being the change you want to see. So congratulations, and I hope this continues to be a productive area for you. I think it's a really important initiative that you've undertaken, and look forward to seeing how it develops. So we're out of time. So once again, thank you to those of us who stuck it right till the end. Please ensure you complete today's evaluation. We will be sending it via email, and I think it should be in the chat as well. Really important that we hear from you. It's so that we can make sure that we continue to bring speakers that are of interest and valued by our community. As we look ahead to the new year, we will not be having a round in December, given everything going on in December over the holidays. So our next presentation will be on Monday, January 19th, 2026. We will be having Dr. Razel Shulman, and we'll send you information, more details about the presentation as we get it. So please keep an eye out for the flyer. And thank you all for joining. Have a wonderful rest of your day. Bye-bye.